Hello, my name is Dr. Tim Rindlisbacher. I am a sports medicine physician in Toronto. I have labeled this talk as bone stress injury because stress fracture is a bit of a misnomer. There is a range of bone injury, and if you think about bone injury in terms of a continuum, it's more accurate. Back in the old days, we used to think that bones were either broken or they weren't. X-rays demonstrated this. But now we have bone scans and MRIs, and there is evidence that microtrabecular fracture, as in the case of bone contusion or bone bruise, is the most minimal of bone injury. This can progress, or there can be present a stress reaction, which usually falls in the lines of stress throughout the bone, and this can progress or be present as stress fracture, where there's linearity, and the bone can, of course, progress to actual or a complete fracture. So, as we all are aware, there is a balance between osteoblasts, which form bone, and osteoclasts, which resorb bone. And in all of our bones, there is normal turnover, remodeling, which occurs. When there is extra stress happening, however, the osteoclasts begin to begin to resorb bone, and the osteoblasts cannot lay down bone enough. And so it's a bit counterintuitive to think that adding load would not build the bone, which is the normal situation. But for when many factors are involved, the balance is tipped toward osteoclasts and fracture occurs. So in the case of a ballerina who is on point, there's considerable stress going through the metatarsals, and they are certainly prone to stress fracture. And the risk factors for bone stress injury are clear. Many of them relate to lifestyle, training, and in no particular order, they're listed here in terms of heavy alcoholic intake, smoking, low levels of vitamin D. Then you have a complicated syndrome known as relative energy deficiency in sport. This is the new term for the female athlete triad, and this topic is in and of itself massive, and I won't go into it much more other than a little bit of detail to come. Just being female, of course, is a risk factor for bone stress injury, and the biggest issue, of course, is excessive physical activity with limited rest periods. Runners are also prone to stress fractures. So to digress just for a moment to talk about REDS, the relative energy deficiency is essentially a low-calorie intake given the demands of the sport, influenced by many things, but presents itself in terms of impaired menstrual function and stress injury to the bone. There are multiple other body functions that are affected by REDS as well, of course. One would expect there to be some genetic element to bone stress injury, and it doesn't appear to be the case on its own, other than that which we see in having the same types of risk factors in running in family members. So it's interesting to note that only 1% of all sports injuries are stress fractures, and the most common locations certainly depend on the type of sport that one is in. This large series of about 330 stress fractures, was made up with a significant component of runners. And so you see a certain pattern of tibia being 50% of all stress fractures in this cohort, tarsals followed by metatarsals, femoral fractures, fibular fractures, stress fractures of the pelvis, sesamoids, and lastly spine. Had this been a cohort of rowers, however, you may see very different location distribution, of course. I think the main issue to hit home is always be on your guard, and a high index of suspicion is required when taking a history and doing a physical exam. So we are careful to probe the patient for a recent increase in physical activity or training patterns that would suggest limited rest between exercise. There is often a history of pain with ambulation or running, and it's important to find the pattern of pain. So if you do have a runner and the pain starts at the beginning of the run and then actually warms up a little bit, where the pain is less evident or even gone for a significant chunk of the run, but then when the runner stops and begins to be active again, then that pattern is actually very consistent with a tendinopathy. On the contrary, stress injury, I should say, is much more consistent, that the pain really never wanes during the run. In fact, it builds and builds and builds throughout the run. On the physical exam, focal tenderness over the bone is clearly important, and occasionally there is edema in the soft tissue surrounding the stress fracture. When there is no soft tissue tenderness, obviously this is helpful in helping form the differential diagnosis and supporting a diagnosis of stress fracture. It is known that the hop test, having the patient hop on one leg, this reproduces pain in many cases when the stress fracture is present. However, it's not specific. In other words, many situations, many diagnoses will create pain with this test. X-ray is always the initial investigation of choice, but it's not essential sometimes to even order an X-ray. If the diagnosis is quite clear in the history and physical, and the patient is not under extreme pressure to return to their sport, they may be comfortable with proceeding with the treatment based on spec. If the X-ray is taken and is normal, then this can be repeated in 2 to 3 weeks, which is a very simple, cheap, and safe alternative to some of the other investigations I'll discuss momentarily. You can see on the X-ray demonstrated of the lower tib fib region that there's just some fuzziness, loss of clarity between the two cortical regions identified, and this is an X-ray sign of early stress fracture. Many times, however, patients are not comfortable with resting, and they are not comfortable with resting without evidence, and we need to confirm the diagnosis more clearly. So bone scan is an option, as is MRI. And in terms of bone stress injury, bone scans are similarly sensitive and specific to MRI. They're certainly less expensive, and they are generally more readily available. A great advantage of bone scan is that you can compare to the asymptomatic side. You can, of course, do this with MRI by doing an MRI of the other leg, but again, you're doubling the cost and hassle associated with imaging both sides independently. I'll explain why this bilateral imaging is important later on as well. Lastly, there is a downside to bone scans, and that is radiation exposure risk. So we really try to avoid this in children and adolescents in particular. There are some imaging pitfalls, of course, and that is that athletes show abnormal findings on many imaging studies, yet those athletes have no symptoms. And so there, in fact, was a study looking at shin splints where they did MRIs of asymptomatic control runners, and 80% of these folks had stress change or some stress reaction. Mentioned earlier was the linear alignment of stress injury leading to stress fracture, and this linearity on both bone scan and MRI is certainly a judgment call at times. It becomes difficult to tell whether it's truly linear, or is it elliptical, or is it actually round circular area of either increased uptake or signal change with bone scan and MRI respectively. So you need to either solidly trust your local radiologist, or probably better yet, do a personal review of the imaging. Make your own decision. The differential diagnosis of stress fractures is not terribly long, but there are a few important things. Certainly most common is tendinopathy, which can approach the insertion point of bone and give the impression that the bone is actually the problem. There's a well-known condition known as exertional compartment syndrome that runners will typically get. The pain will build during the run, and if they rest, the pain goes away, and this can be interpreted as a bone stress injury situation. There's a wide range of benign and malignant bone tumors that can mimic bone stress injury as well. And lastly, in certain regions of the body with skeletally immature athletes, you can have a number of apophysitis diagnoses. So, the location of the pain is really key in determining the differential diagnosis. And shin splints, once again, is a very common example of this, where the medial tibial region is painful, and there is in these cases there is no focal bony tenderness, but rather it's more diffuse along the mid to distal region of the medial tibia. Helpful is the fact that there typically isn't edema, whereas there can be with stress fracture. More and more we're seeing non-athletes get stress fractures. This good example of this is when patients want to do a charity walk, and so they're sedentary individuals and they start to get active, and suddenly that abrupt change from their usual leads to stress injury. I'm going to go through a number of slides now showing bone stress injury. We're starting with an X-ray of a young lady. This is her right foot, and you can see the second metatarsal has already gone through, progressed to rather, actual stress fracture with bony callus forming over the second metatarsal neck region, neck and shaft region. What I'm going to show next is the same individual X-ray taken 3 weeks later, and you will see that the fourth metatarsal is also demonstrating callus formation from a fracture. And in fact, if you're able to look back to the original image, you can get a sense that there actually was a stress fracture forming at that time in the fourth metatarsal. It was just difficult to see and missed by the radiologist because of the obvious second metatarsal stress fracture. it's important to note that this patient, upon first presenting with her second metatarsal stress fracture, was actually still running on that fracture. The third slide is a close-up of another patient with a second metatarsal stress fracture, and this individual 9 days prior had a completely normal x-ray. So this case demonstrates how it can be, x-rays can be repeated and demonstrate stress fracture shortly after. One other important finding is that this individual also has a medial sesamoid, a medial bipartite sesamoid, I should say. And why I say it's important only in that it's not a stress fracture or any kind of fracture. It is present in about 30% of the population. Bipartite sesamoid is very similar to a bipartite patella. One last interesting situation with this case is that the ultrasound was in fact the test that initially picked up the second metatarsal fracture, and so the final slide of this case demonstrates an ultrasound which demonstrated a cortical irregularity. It was then that the patient was sent back to get x-rays, which were just discussed. The next slide is in fact a bone scan of the lower extremities demonstrating a fibular stress fracture on the far right bottom. You can see that the left side demonstrates a fibular stress fracture about mid-shaft, and the image just above that demonstrates the right side, the other leg, which is normal. These side-to-side differences are clear in the anterior and posterior bone scan delayed phase images that we see here as well. This next slide is the blood pooling and delayed images of a different patient. And on the far right, you see the delayed images with the big red arrow pointing to the calcaneus, pointing to a calcaneus stress fracture. This is obvious, of course, on the blood pool images on the right, on the left as well, on the left side of the slide. Bone scans are done, of course, in triple phase. There is a flow phase, a blood pool phase, and then the delayed phase. The bone images are the delayed phase, of course. The next two slides demonstrate a case of a pubic stress fracture. Not very common, but pelvic stress fractures can occur. In this case, you see there is sclerosis of the medial pubic bone on the left side, which is the right side of the screen, compared to the other side. When this patient was imaged on MRI, the big white arrow is pointing to a area of decreased signal intensity, and one does not see that on the right pubic bone. There's also surrounding edema demonstrated around the stress fracture. The next case is demonstrating a stress fracture of the pars interarticularis. One can see the very close to the superior facet of this level, a defect in the pars interarticularis, typically associated with repetitive spinal extension, which loads the facets and eventually leads to stress through the pars interarticularis. You will likely remember that the oblique images form what looks like a Scottish Terrier, and this Scotty dog, when it has a collar, is deemed to have a stress fracture.